All right, very good morning and welcome to today's resident lecture. This morning we're going to talk about retroperitoneal sarcoma, and the talk will be held by Anke Meyer. Thank you very much. Enjoy.
So my topic is retroperitoneal sarcoma for today, and I just want to go through the agenda about the epidemiology, the anatomy, the clinical presentations of patients, the diagnostic evaluation, staging, the therapy, the surgical approach we have, the follow-up and the outcome of patients. So talking about soft tissue sarcomas is a wild field, and epidemiologically you see that it arises from skeletal and extraskeletal connective tissue. It's a heterogeneous group and it's really rare in adults. It's about 1% of all malignancies in adults. About the anatomic sides, we have to keep in mind that it's all over the body. It's the thigh, the buttock, groin, the upper extremities, the torso, the retroperitoneal part, neck and head, but I just want to focus in the retroperitoneum. So retroperitoneal sarcoma is relatively uncommon. It's about 10 to 15% out of all tissue sarcomas, and it's about 1 person in 100,000 population that occurs from sarcoma. It's equal in men and women, and it's about mostly in the 5th to 6th decade of age. And there are some risk factors identified. There's radiation, a chronic lymphedema, or contact to PVC, and it's sometimes associated with genetic abbreviations like the neurofibromatosis, the Lee fragmenti, the Gardner syndrome, and others. So when patients present with a retroperitoneal sarcoma, mostly they have few symptoms. And this is associated with a compression or invasion of the retroperitoneal mass. We have the median size at the diagnosis is about 15 centimeters. So when you think that somebody is presenting with that big mass in the body, you have some symptoms coming up from them, and this is mostly abdominal uncomfort, sensation of abdominal pressure, an impotence, early satiety, lower extremity edema, neurological musculoskeletal symptoms. There's rarely ascites. This can be due to a portal vein compression, rarely paraneoplastic syndromes or flu-like symptoms, and sometimes there is also a loss of weight. Even they gain weight with the big tumor mass. Differential diagnosis of the retroperitoneal mass are really important because there's about approximately 80% of all masses in the retrocavity are malignant. So we have to think about what would be another diagnosis of this. And this is about a lymphoma. 33% of all retroperitoneal masses belong to lymphomas. There is metastatic lymphadenopathy. There is neurogenic tumors, paragangliomas, pheochromocytoma. I think this is one of the most important, and germ cell tumors, metastatic testicular cancer, and teratomas. So this have to be kept in mind when we're going to the diagnostic evaluation. We are starting all over as usual with the medical history, and there have to be symptoms have to be asked, like for lymphomas, for pheochromocytomas, like fever, weight loss, night sweats, hypertonia, and if there is any genetic predisposition we're knowing from the family or surrounding. Also the physical examination, I know everybody knows, it's about the abdomen, the chest, and in young men we have to think about the testicles if there are germ cell tumors or teratomas. The laboratory includes the normal lab we are making, like the hematology and the lab results from the kidney, the liver function, and sometimes the gut inflammation, but also including like tumor markers for the suspicious germ cell tumors, the LDH, the FPA, and the beta-ACG. The radiographic evaluation is with the CT, an MRI, or a PET scan. I will come to this later. And a biopsy. So this is more or less a flower of things we have to get through with the patient coming with a retroperitoneal mass. The radiographic evaluation, we can have a CT scan, contrast enhanced, an MRI, or a PET scan. So mostly and most common is the abdomen and pelvis and chest PET scan. The abdomen and pelvis to see where the mass is lying and what size it is. The chest, it's a rule out of metastasis more or less. There is a good definition of anatomic relationships to the surrounding tissue, so we can get an impression where it's lying, what is the connecting part. And we often have, about the appearance of the tumor, a clue which histological subtype it might be. I will come to this later. An MRI is indicated if we have an allergy to any contrast, or if we're thinking or having the impression that it's involvement of a bone, muscle, or spine. And another one is, if we're going for radiotherapy, we first go for an MRI to get an assessment of the local tumor and the edema to plan the radiotherapy exactly. There is no established PET scan in sarcomas, but in doubt with lymphomas, we're gonna do a PET scan before. So you can see here the different radiographic evaluation, like the PET scan. Over here, the PET scan, and you don't see that there is the mass has any PET positivity. The fat, the lipoma, like with it's the same color with the fat all over. And there is the CT scan, you see the big mass. The biopsy we have to take afterwards, it's the gold standard. It's a percutaneous core needle biopsy and has a low risk of complications. So there was one study showing that 2 out of over 500 patients have a fear of tumor seeding. So this is a complication we can take in risk, and it's the treatment we are going for can verify very dramatically. So it's the gold standard, we have to get a biopsy. After the biopsy, we're going for histology and getting the routine histopathology, the immunohistochemical staining, a PCR, because there are variant translocations of the tissue, and the FISH analysis like the MDMT2 over here from adipocytes showing the dedifferentiation. Why is it so important? I want to go through the histology, and the first and most known is the liposarcoma. You can see here it rises from adipocytes and inflammatory cell infiltration, and there are 2 parts of it. It's a well-differentiated, it's a low-grade, that's the most common tumor, and the dedifferentiated, it's a high-grade tumor. There is leiomyosarcomas. They arise from the inferior caudal vein, from small vessels, from the gastrointestinal tract and the uterus, and it's often more large in size when we diagnose. They're unclassified and undifferentiated tumors, more or less also mixtures, about 10%. The older term was malignant fibrous histiocytoma, and it comes often from peripheral nerves, undifferentiated sarcomas, synovial sarcomas, and a mixture. And there are variant ones. I think everybody heard about it in the study. Childhood, Ewing sarcoma, rhabdomyosarcoma, fibrosarcoma, desmoid cyst. This is all over in the varia. But the most common are the first 2 ones, the liposarcoma and the leiomyosarcoma. So I think I want to focus on this today. The biopsy, there is a study published this year about showing the diagnostic accuracy of percutaneous biopsy in retroperitoneal sarcomas. They looked up to about 240 patients. They had a retroperitoneal sarcoma between 2005 and 2016 in European sarcoma units. And they matched the histological tumor type and grade with the biopsy correlated to the postoperative taken from the specimen, to evaluate if there is any diagnostic accuracy. And they showed that there is a high specificity for high-grade tumors and a positive predictive value of 85% and a negative predictive value of 78%. So we can identify with this measurement the high-grade sarcomas, and this is more or less getting to a neoadjuvant therapy in high-grade tumors. This is under discussion and under research. So it's really important to get the biopsy first. Staging of these tumors is most common. We all know the TNM staging and the Union for International Cancer Control. We have to get distant metastasis, most common in lung and liver. And in 10% of all these cases, we have the metastasis at the time we diagnose the tumor. Mostly, the tumor has metastasis with the leiomyosarcoma and the dedifferentiated liposarcoma. I will get a quick impression about the TNM staging. Is more or less kept in 5 centimeter steps. So a T1 will be 5 centimeter or less, and then it's rising up till a T4 with more than 15 centimeters in dimension. Then it's pretty more or less simple. Any lymph node positivity will get an N1. Any metastasis will get an M1. There is no differentiation in that. And we grade the histological part with mitotic count and necrosis score. I want to show the grading, which is down up there. And it's divided for me in 2 parts because we have an N nil, and any M nil is all a grade A 1A to 3B. And any N1 or M1 down there is always a higher grade 3B or 4. So that any metastasis lymph node or metastasis distant is a better grading than without. This is a multidisciplinary approach we have in the therapy. So there is no guideline with all other cancers, or with some other cancers we are knowing, but there are recommendations from groups all over the world. The most known is the National Comprehensive Cancer Network. There's the European Society of Medical Oncology, and there's the Transatlantic Australasian Retroperitoneal Sarcoma Working Group. So it's pretty. And this is a combination of surgical resection, radiotherapy, and chemotherapy. And there is no one-fits-all guideline or one-fits-all patient because it's so different and it's so uncommon. So there is a really lack of high evidence levels. But the most important for the decision is what histological grade we have, there is any presence of metastatic disease, and if there is a possibility to do a total resection. The therapeutic consequences coming up with this, the liposarcoma, I told you already, we have well differentiated, a low grade, and there is no metastasis in this part. They don't metastasize. And we have the dedifferentiated, the high-grade tumor. They have the potential to metastasize, and they have the potential, a high local recurrence rate. The leiomyosarcomas, they have often lung metastasis, more than liver, and they have the risk to spread peritoneal. The unclassified, undifferentiated, and the varia, I will let by side. They are not specific. There are so many. The first treatment we have for the liposarcomas is a surgical resection and the radiotherapy. For the leiomyosarcoma, it's also a radiotherapy, more or less, a surgical resection. And on the research, there are a lot of studies about a neo or adjuvant chemotherapy that could be taking place in here. For the unclassified and undifferentiated, there are variable protocols, especially for each tumor identity, and also for the varia, but I will just show two here. The Ewing sarcoma has a special chemotherapy regime, and the desmo is almost watchful waiting. So the first two ones, I think, are the most important ones. Surgical concept, the surgery is in this time the only chance to cure. So we have to get an en-bloc resection with the capsule and the full tumor. We have to get a negative margin microscopically. There is possible no rupture of the capsule. We have to ligate all the blood supply and have to precise anatomic margins if possible. And sometimes we place clips for radiotherapy or for any imaging followed up. Because the aim is the radical resection, this is the way we can cure the patient. So from the anatomy, I would just ask my colleagues, this is a retroperitoneal mass. What do you think could be an organ abdominally which could be involved in the retroperitoneal mass?
For example, colon ascendens, descendens, kidneys, adrenal glands.
Perfect. I think this is just one picture. It's about what you told, the colon apart, duodenal knee, pancreas, kidneys, adrenal glands, also vessels like the vena cava and the aorta. So preparing the surgery, I told you before, you have to keep in mind that we have a preoperative management. We have to think about if we have to make a stoma placement, perhaps we need a colonoscopy, a scintigraphy of the kidneys if we want to have to resect one of them. Perhaps we need a liver function test to know how it's working. And if there is anything we have to do with the vessel, that angiography or duplex sonography. I will show you the resection margins. And there are two resection margins, more or less, the right side and the left side. For the right side, there is the right kidney, the adrenal gland, the ureter, the bladder, the top of the bladder, some more or less, a muscle fascia, the colon ascendens, the inferior caudal vein, and sometimes, rare, the pancreas head and the duodenal knee. The left margin is on the left side, green one over here shown. It's the left kidney, the adrenal gland, ureter, bladder, it's most the same. Muscle fascia, the spleen, and the pancreatic tail, which can be moved, and the colon descendens. Sometimes it's also a tumor up there with the mesenteric root. So this comes to my next criteria: is there any surgical criteria of unresectability? There is some under discussion which have to be discussed in the interdisciplinary. If there is an involvement of the mesenteric root extensively, we have to think about if we can resect or not. If there is an involvement of a spinal cord, we have to think if there is any possibility to get surgical resection. If there is peritoneal seeding, there are some studies going on about what to do with peritoneal seeding, but sometimes it's not a good idea to go for surgery then. And if there are distant metastases which are potentially not resectable. But somehow there are palliative concepts to reduce symptoms because of this huge mass in the abdomen. There is sometimes the indication to do a reduction of the tumor mass. I will show you here pictures from a patient we operated here in Zurich. It's a patient with a retroperitoneal sarcoma, and you see here the colon, and you see the kidney inside here with the tumor connected. If we turn it around, you can see here the forceps is in the inferior caudal vein, and this was replaced with a graft afterwards, after the operation, so you can see the muscle. There's the margin line, there is a over here down there. The follow-up of these patients is recommended to do a physical examination and to do abdomen and pelvic imaging. And this is more or less the first 3 years we have for every 3 or 4 months. Afterwards, if this is negative, we can go twice a year for in the 4th and 5th years after surgery. And more than 5 years, if there is also nothing found, we can go annually. But there is no defined recommendation for chest imaging. But in high suspicious tumors, high-grade tumors, and if there are any lung metastasis or any potential to metastasize, it's indicated to do also a chest scan. The outcome of retroperitoneal sarcomas, it's less satisfactory than soft tissue sarcomas on other sides, like on the extremities, because it's often larger diagnosis and it's had an anatomic situation with involvement of abdominal organs, and we all know that this can also get to some point of problems. There's a high local recurrence rate, about 50%, all of them do recover. We have a higher grade of dedifferentiation. This is one risk factor, and the other one is a liposarcoma with a histology of a dedifferentiation and a positive resection margin. There are distant metastases up to 30%, 20 to 30%, and it's mostly in the lung and in the liver. This is a nomogram which was established. This one is published in 2013 to get an impression of the 7 years disease-free survival of patients having a retroperitoneal sarcoma. So you have here a tumor size, the grading, the histologic grading, the subtype histologically, and the focality, so if there are metastases or not. And you match them with the points up here in the line, and afterwards the total points, you can see how the 7-year disease-free survival will be. Also, this is available right now in the Times as an app. So, but you can get an impression what would be the 7 years disease-free survival. This is a Kaplan-Meier curve showing for patients underwent surgical resection, primary surgical resection, and you see that after 48 months, there's about 60% overall survival. So looking this up after primary extended resection more in detail, we see an overall survival of the differentiated histological types. And I just want to focus on the one we had before. There is a more or less good overall survival for the well-differentiated liposarcoma. There is the leiomyosarcoma, more or less about 60%. And there is the dedifferentiated high-grade liposarcoma. So you see that there is a difference between the histological types in the outcome of the overall survival. Looking up the same identities for the local recurrence, you see that there is the dedifferentiated high-grade liposarcoma are more often to recover. There is the well-differentiated liposarcoma next, so both liposarcomas do have a local recurrence more often than the leiomyosarcoma. They don't recover that often in the same place. There are distant metastases. The leiomyosarcoma is the one most known for distant metastasis. Then there is the dedifferentiated high-grade liposarcoma. And there is no metastasis for the well-differentiated liposarcoma, as I told you before. So, to sum up, the retroperitoneal sarcoma is a rare disease. The biopsy is obligatory to know which way we'd go, which treatment we're going to plan. The therapy concept is multidisciplinary, has to be discussed in a conference. Their radical excision is the only curative way we can treat it, and we have a high local recurrence rate for most of the tumors. Thank you for your attention.
Thank you very much. Very nice presentation, nice slide of difficult disease. Maybe I just ask the first question to Professor Lehmann, who is here. Obviously, this is a complex surgery we have seen here requiring pretty expertise and many disciplines. So there is this sarcoma board. I would like you to tell us a little bit who should be in this sarcoma board in order to offer the best treatment. What is not seen here is that some of these patients, when they are operated by inexperienced surgeon, then it's a disaster because we can get very good results, not only surgically, but also arterial resection, etc. So it's very important to have a special board. We have a sarcoma board here in Zurich. Would you tell us what's the ideal sarcoma board to treat this patient the best?
Thank you. Very interesting question. It's actually very, very simple. It needs dedicated and experienced people that regularly meet up and discuss those cases. That's like in most other specialized boards as well. I think the special situation for sarcoma, particularly retroperitoneal sarcoma, is that it involves so many disciplines, particularly from surgery, because they are not in ideal anatomical positions, but often involve the spine or transition zones like the thorax and the abdomen. So it frequently involves several surgeons, for example, during an operation, and of course radiation therapists or oncologists before and after the intervention.
Who follows this patient usually? The surgeon, or is that still the board? How it works?
Well, the board is not directly accessible to the patients. Usually it's one specialized team that follows the patient, and it depends a bit on the tumor diagnosis. Liposarcoma, for example, are followed by surgeons because surgery is the main therapy and recurrence is usually treated surgically, while, for example, leiomyosarcoma or other diagnoses like Ewing sarcoma, they frequently metastasize and they're usually followed by oncologists.
Great talk, thank you very much. I have a question concerning radiotherapy. You mentioned that in your talk already. What's the role of radiotherapy, meaning when do you offer radiotherapy to the patient, or that is a specially selected patient? And do you offer them as a neoadjuvant treatment or do you prefer as an adjuvant treatment?
Well, the answer is not easy. There are tumors that clearly profit from neoadjuvant radiation, and one of the classical examples are high-grade sarcomas like Ewing sarcoma that can also occur in adults, not only children, and or leiomyosarcoma, for example. They regularly get radiation before resection. It's more difficult for liposarcoma. We still tend to irradiate high-grade sarcomas, and particularly the borders of the tumors where you think you might have difficulties to get an R0 resection. For example, in the retroperitoneum or towards the neuroforamina, there it can be a bit more difficult. It's less clear for well-differentiated tumors. And there is an upcoming study that may show that the role for radiation therapy is less than what we thought during the last years. But this study is not yet published, so it will come in the next weeks.
I have a follow-up question on that one. Thank you very much for the nice talk. Is there a role for intraoperative radiotherapy?
Some people do that. That's right. It's a very infrastructure intensive. So you need a lot of, you need a special OR, you need radiation therapists going to the OR, and there is, to my knowledge, no study who has shown a clear benefit for that treatment. So most large centers don't do it anymore.
Thank you for the nice talk. I have one question to the liposarcomas. You showed nicely that the well-differentiated liposarcoma do not metastasize, but can they de-differentiate over the course of time?
They can, but most don't do. I think over the years it is possible. It's also possible that you have, and that's probably more often the case, that you have de-differentiated areas in a big bunch of tumor that may cause later recurrence or metastasis. But that's who's first, the hen or the egg? So I think that's a difficult question to answer.
How should a surgeon handle an incidental finding in the mesentery, a mass, during another laparotomy? If you find an incidental mass in the mesentery, for example, should you do a biopsy? Should you do cut it out completely? How should you proceed?
That is a religious question. I mean, I would probably call, discuss, and then you have to come up with a decision. And the decision may be right or wrong. That's always the risk. I don't know. I think you cannot answer this question straightforward. If you think it's a cyst, it's the right way to resect. If you consider it might be a desmoid, a mesenterial desmoid, then it's probably better to take a core needle biopsy and wait. I think that's up to your judgment.
Thank you for a great talk. I think those tumors tend to recur quite frequently, so up to 50%. I think the most complicated situation is when you have actually a recurrence in the patient, and this makes the treatment even more complicated and underlines also the need for really to discuss those patients in a sarcoma board, because then really you have added value maybe by neoadjuvant radiotherapy, etc. It's just a small comment. Thank you.
I think there are a lot of studies going on with the treatment for the different, also the recurrence of the tumors.
No more questions. So thank you very much, Anke, for your nice talk.